This is Winchester Academy.
For tonight's speaker, Dr. Melissa Stiles went to medical school at the University of Iowa, so we're probably not going to talk about the football game.
I became a Badger fan.
She did a residency in family practice in Madison, did a residency in geriatric medicine at UCLA, and is now back at the department in Madison as a full professor of family medicine in the UW Department of Family Medicine and Community Health. So she was introduced to me via a residency friend who's also in the department, retired like me, but he had high marks for her and gave us a good recommendation. So you can thank John for getting you here. John used me. And she tells me that her passion is healthcare reform, and I think that will be evident in her comments. Please welcome Melissa Stiles.
Thank you very much. So we'll start with a few questions. How did we get here? How did we get here? $3.3 trillion that we're spending every year. That translates to $10,000 per person for health care in the United States. Does anyone feel they're getting $10,000 worth of health care? From the VA? All right. Does anyone know what $10,000 of health care is worth? What that means in the United States? It means it differently if you're at the VA, or if you have Medicare, or if you have private insurance. It depends on where you are regionally. It's a vast difference. We don't know even what that means. So today what I want to do is start with framing the issue. What are the main problems? What are the main challenges? And what are the potential solutions? Because I think there is hope in this issue, but right now we definitely are mired in a cycle of spending and spending and spending. It doesn't seem to have any end, and we're just not getting the outcomes in having a very good system. So first, some disclosures. I'm at the university, but the views expressed are my own. I'm also a steering committee member of Physicians for a National Health Care Program, which advocates for single payer. I'm open to other solutions, but definitely that's one of the leading organizations working on healthcare reform, as well as the National Physicians Alliance. I'm not going to sugarcoat things. There's not going to be sugarcoating. That's my other disclosure. I think we need to have frank discussions, and we need to be frank about where the costs are coming from and what needs to be addressed, because it needs to be addressed on all different levels. So what are we shooting for? What's the Holy Grail? What are we wanting in a healthcare system? And with the Institute for Healthcare Improvement, we want to have a high quality system that we take care of the population and individuals. So we have very much pockets in the United States where some of this is done well, but overall, we're not doing a good job. So in framing the issue, we're looking at, and you probably may have seen these graphs before, but when we look at healthcare spending, the United States is the leader of all the developed countries. And we're up to almost now 18%, 20% of our gross national product is on healthcare, 20%. And so also I want you to stop and just reflect on that number. So we look at how much we're spending, but also what that means. That's a lot of people that are employed in healthcare. So when we look at solutions, we also need to consider that, because we now have this medical industrial complex that we need to address, but that also means real people. That's me. You know, there's a lot of us in healthcare, and so that's where the tough questions, the tough conversations are. How are we going to fix a system where so many are employed and our economy is really dependent on it? So we have the discussions, and a lot of this was raised in the last election. So Bernie Sanders definitely was able to get the message out. You know, we're spending way too much, we're spending way too much. And so this slide, what it looks at is, well, how much are we spending per person? And that's about $10,000. Well, how is that different from other countries, other developed countries? And how much of that is public monies, and how much of that is private? So when you look at this, the yellow is the public monies. So we spend about two-thirds already of that 10,000 is public monies. And that's more than many of the developing countries that are doing much better on a lot of other, the quality indicators are spending. So when they say, people say, oh, we don't have the money, we have the money. I mean, we're spending way more money than other countries that are getting much better results. So the fact that money in itself is not the issue. So this was, the Commonwealth Fund is a nonpartisan organization, and they do a lot on healthcare policy. And so it's a place that I go to for a lot of my data. And every year they look at the top 11 countries, the developed countries, and they look at markers of quality, access to healthcare, cost. And year after year, the U.S. continues to be at the bottom overall. And again, we're doing some things well, but really in many of the markers, we are just lagging behind all of the other developed countries. And this is just another graphical example as we look at how we're spending the highest healthcare spending, and then in terms of overall performance is at the top. So we're at the lowest in terms of overall performance, but yet we spend the highest. So we can't keep doing this. It's just been this constant cycle. So here's my elephant, Terry. He was wondering when the elephant was going to come out. I'm right here in the room and no one even acknowledges me. So I think we've had these conversations around and around and talked to people, yes, it costs too much, it costs too much. How many have seen that over the past 3 years, their co-pays, their deductibles, their co-payments go up? And just, you know, to a degree where you're really noticing it. And we need to address that elephant in the room. We need to say, what are the major drivers for this? Where can we start to whittle away at this? Because we can't keep becoming number 11, and we can't keep spending just to no end. So this was an article, it actually was about, this now is 15 years ago. And you know, looking at, well, why does it cost so much, and you know, healthcare costs so much? And so these are economists. It's like, it's the prices, stupid. It's the prices. And there's a lot of now more information coming out. We're looking at comparison pricing, not only between countries, but also between regions in the U.S. But we really do, we spend so much more in pharmaceuticals, we spend so much on surgical procedures, we spend so much on imaging than other countries. And not only is it the price, but it's also the intensity of services. Intensity of services. So how much is being done? So if you have an MRI in a region, there's going to be more MRIs in that region than if the MRI is not in that region. So that intensity of services is higher in the U.S. Interestingly, when we look at the other developing countries, it's not that they don't seek medical care more, In fact, many countries, and Japan as an example, has much higher office visits per year per person and higher number of days in the hospital per person. So it's not that people don't seek care in other countries, it's that intensity of services and the cost. So why does it cost $800, $900 for a CAT scan in the US on average and $125 in Canada? Why is that? Why does it cost $75,000 for heart surgery in the US and $15,000 in Denmark? So it's really this disparity. And as I said before, it's not just by country, because you can say, well, that's, country and they're doing things differently. But you go by regions, and even within the same city, you'll see distinct differences between what people are charging. And why one hospital is charging this for a knee replacement and it's $20,000 more at this hospital. There's no rhyme or reason to the cost. And we need to get our hands around that. So one of the big drivers, and one thing we have to have really, and it is being addressed, is what we're wasting. So when we look at healthcare costs, which is about $3.3 trillion now, it's estimated that almost $1 in every $3 is either waste or unnecessary spending. So that includes doing unnecessary tests. And it used to be, we would be interns in the hospital going in, and it was this knee-jerk reaction. Okay, they're in the hospital day one, they get these tests, we just keep ordering them. Daily labs, daily labs, daily labs. They never changed, but we kept getting them. And so now we're like, oh, well, maybe we don't need to get labs every day. And so there is that acknowledgement, but there's a lot of this kind of just things that were just done routinely that didn't need to be done. We also have more information now. And so when we look at issues like how often should I get a pap smear? So when I started practicing, women started at 18, they came in every year, forever, right? And so now I look back, it's like, oh my goodness, all of those unnecessary pap smears, because we didn't have that information that it really wasn't necessary. And now we're doing more risk-based prevention. And based on what your risk factors and your history, it determines how often you need to have a test. So we are making some strides, but still that unnecessary testing is there. Part of this is defensive medicine. And so I think an example will be, you go into an emergency room, you don't know any of the physicians or staff there. They may have your record, or it might be buried somewhere. And you just start getting tests, and you're like, well, I just had this test, and they're like, well, we can't access it, so we're going to do it again. Not uncommon, but these all add up. So unnecessary testing. The other is looking at, another big bugaboo of mine is just administrative costs. So what is happening, how much are we spending on administrative costs in healthcare? And it is huge. And that's an area that also could be really affected by going to a single payer system or another system, but we need to really address the administrative costs in medicine. And I'll have more on that in just a moment. So this is part of the no sugar coating, part of the, is that, I'll talk about physicians, I'll talk about myself here, I'm included in this group. So what I wanted to talk about, there are a couple things that are not as well known in terms of what happened with prices over the years and costs. And one is a little known committee. It's called the Relative Value Committee. It's within the American Medical Association. This committee basically sets prices, or they suggest a price to the Center for Medicare Services, CMS. And about 95% of the time, CMS will accept whatever the recommendation of this committee is. So that's the important thing to know. So they basically set the prices. And with this was, it started with a very good intention. So what happened was in the 90s, there was a study that was commissioned by a Harvard research team to look at, from Medicare, to look at how can we charge more evenly, or how can we make sure that we're charging something that includes the intensity of the service, how much skill is needed, and how much time is involved. And so they came up with what's called a relative value unit. So number one is your office visit, and then from there went up to, I have brain surgery, that's going to be so many relative value units. So what happened is over time that procedural codes, so if somebody had a procedure, any type of procedure that they wanted to have approved, that would be usually a higher RVU. And so what happened over time is that physicians that in specialties that did more procedures became higher reimbursements because they were mainly doing procedures. And the graph shows that there's always been an income gap between specialist primary care physicians, but it just really widened since the introduction of this committee. The composition of the committee was about 2/3 specialists, and there were a handful of primary care physicians. So there has been some press about 5 years ago, kind of like that, we call our little secret got out. And so that has now gotten under more scrutiny, and also along with that, a lot of systems have gone from termed fee for service. So charge and your compensation is based on what you basically brought in, to more of a value-based compensation that is based on salary plus other measures. But we still have a long way to go. But I think for the physicians, we have definitely this gap now, and the question is, are physicians paid too much? I think probably a lot are. And that needs to be addressed because that also the way that graph is going can't be sustained. So that's where we need to have a hard look at how that is going to work. Another driver is, in my mind, is the electronic medical record, electronic health record. We have spent trillions in this country. Since about, this is around 2000 is really when they started to emerge. The VA has had a great medical record back into the late 80s. And in the private sector, the return on investment just has not been there. We have not seen, the big things were, it's going to save costs. You won't need a transcriptionist. You won't need this. You won't need that. Well, costs have gone up. It definitely has not, it has affected costs, but not in the right direction. It is, when it works, and it's great, I think the best thing is around the medication management and not making mistakes and keeping track. But the pharmacist is left out of the group. So the pharmacist doesn't have access. So they don't know, they're going by the patient making, and so it's really still not a great system from the pharmacist aspect because they can't look into the system, at least where I'm at. And then the interoperability is not very great. I'm in Madison. Epic is everywhere. There are 4 different Epic systems in the 4 different health systems. And there's one system that can go to each of the hospitals. If I have a patient with that insurance and they have a lab, you would think, I can just go into the chart. But no, it is buried in a different system that I have to pull out. And so we're a long way from really utilizing what the EHR could do. When we look at chronic disease management, we would think, okay, this is great. This is what the electronic medical record, we can pull data for all our patients with diabetes. And you would think that that would be like top and center of priority. No, we had to pay more to add it on. The EHRs, again, this is the no sugarcoating, and Epic was, the CEO came from insurance, and it was built on the basis of coding and billing. That was where the platform was built on. It wasn't built for the patient, it wasn't built for the physician, it was built to code and bill. And things were kind of added on top of that. So we're now at a place where our systems are paying a lot to try to maintain EHRs. We have all of these cottage industries, and I don't know if you ever go to the Madison Airport, but you see all of these billboards, many billboards up, and they're all basically these new businesses that have spun off to help support your EHR, because you have to keep spending to update, and there's always updates. And we just haven't had that return on investment. So it's it definitely is an area that needs attention. And one thing that's really striking, for every hour now of patient care for a primary physician, it translates to about 2 hours of what we call in Madison epic time. There's also a new term, pajama time. One of my colleagues just wrote an article about pajama time with Epic. And they were able to do time walks, so you could see when was the clinician and nurse practitioner being on the chart. And it was between like 9 and 11 p.m. So after the kids were in bed or after dinner. So it has generated a lot of angst among the physicians and nurses and hospitals. There's no one you can say, oh, I love this. If you know someone, let me know. I'd like to talk to them. But unfortunately, the potential has not been realized, and we are throwing a lot of money into these systems where we're not getting the benefit. So as I alluded to before, the administrative burden is huge, and we just keep seeing this go up and up. When I talked about initially coding and billing, when we started having coding and billing seminars on how to optimize your coding, it's like, this isn't right. You're telling me how to code so we can capture more? Like, this isn't what a healthcare system should be. This is not what a healthcare system should be. And so the administrative cost is going up, especially in terms of the private sector. And this is just a fun slide. So the growth of administrators and managers versus the growth of physicians. So the physician, and the yellow and administrators just keep going up and up and up. So, something's got to give. So, we have, not in the U.S. a healthcare system, we have a healthcare behemoth. We have created this unbelievably complicated system and put a patchwork together of public and private insurance. The ACA is kind of trying to bridge between them. And all of these agencies now are involved. And it is just chaos. And so you wonder why you're seeing physicians and nurses burn out and stop practicing early. And I just, have seen nurses working with nurses where we work side by side. And now they're basically doing, basically doing paperwork for the electronic medical record. They hate it. They wanted to be that patient contact is what they trained for. And we created these systems, and now it just, then all of this administrative burden and it's really burning people out, and it's really something we just can't sustain it. So I just wanted to take a moment too to comment on the Affordable Care Act and just where my thoughts are about that in terms of related to this. Is this definitely, it is part of the issue or part of the solution. So I think the Affordable Care Act had some really significant, what I would term pillars. But the foundation was always a little bit on soft sand. It wasn't a firm foundation. The foundation remained within for-profit insurance companies. But the pillars and what they were trying to do in terms of trying to stop some of the egregious acts of insurance companies, denying people or stopping insurance because of pre-existing conditions. And I had patients over the years that were denied insurance because of the benign, a menstrual problem or a benign cyst. I mean, it was ridiculous. And they also, the other thing that was really good is that first dollar for preventive services. And so that you could have your preventive exam, and you could have preventive testing, mammogram, pap smear, et cetera, without a copay, without it going against your deductible. The other good thing is what they looked at was the 80-20 rule. That of your premium, 80% went to health care. And only 70% would go, 20% would go to administrative purposes or marketing. Those now are all being chipped away. And so the recently rule is going to a 70-30. There have been plans that are approved called the kind of high deductible plans that won't have that preventive coverage. So we're starting to see this being chipped away. And when we look at, how do healthcare systems sustain themselves? You really need to have everybody in. You have to have a pool of people. You can't just have sick people get insurance. You won't be able to afford that. Those people won't be able to afford it. So you need to have everybody in. And so they're having now, trying to eliminate, possibly eliminating the mandate. These are all just kind of whittling away at those pillars that was already around what I felt was a pretty soft foundation. So it's going to be hard to see this being sustainable in view of all of the other issues, and also seeing, when we look at the cost, in the ACA in the first 2 or 3 years, there was a slight bending of the cost curve. It never went down. It just wasn't going up as steeply. But now we're starting to see it go up as steeply. So it's really an issue. I don't think it's going to be addressed by just fixing the ACA, because there are so many other issues I've just talked about that are still going to be there. So now that we're all depressed, we're going to finish on a positive note here. So what are the potential solutions? Where can we start to make some inroads in this very, very large elephant in the room? So when we look about how doctors have been paid, how hospitals have been paid, and going from not just a fee-based payment, this is what I charge and this is what you pay me, but knowing you're basing it on what the value is. And so there'll be, for hospitals, what are called bundled payments. So when we look at, if you're going in for a knee surgery, so instead of paying for the surgery, the anesthesiologist, the post-work, the physical therapy, the IV, et cetera, and you get the bill in the mail and you're like, oh my God, how do I even get through this? There'll be a bundled payment that they'll get so much per knee replacement. And so that is, it's based on the area that someone's in, the risk of the patient, so it'll be based on that. But looking at kind of bundled payments rather than everything just being fee for service. Then we want to make sure that we're getting value. And so we look at physician reimbursement also, that we're getting, it's not based on how many toenails or skin tags I take off. And I once joked, I used to, it was incredible that I could get more taking a skin tag off than having an end-of-life discussion with somebody. That's going to change, but it was just like, this is wacky. Our system is just wacky. So looking at those coding and how we're really reimbursing and what the real value is. So value-based payment in healthcare and payment, we're starting to see kind of a sea change. I know in the system I'm in, I was just talking with someone in population health, and about 40% of our payments now are value-based. So we're starting to make the change. It's a big lift to go to a value-based payment system. Physician stewardship. So when I talked about when I was an intern in the hospital and just ordering tests every day because that's what we did, you ordered daily labs on everyone, that there's a lot of great initiatives looking at this issue. So one of the leading ones is what's called the Choosing Wisely campaign. And now there are about 24 medical specialties that have signed on to this. And what they have is a list of things that are not needed or shouldn't be done. You don't need a routine chest x-ray for a pre-op exam, kind of in general. There's certain indications, but it would be, okay, you come in for your pre-op, you get your EKG, you get your chest x-ray, you get the routine labs. You don't base it on routine labs anymore. It's all based on what your risks are, what you're the individual, rather than just, okay, everybody gets the same thing. So every specialty, for sinusitis, you don't treat unless it's been going on for 2 to 3 weeks. For ear infection. So there's things that have changed over the years now that we have better evidence. So each of these medical societies has put down like, okay, here's my top 10, top 20 things not to do or to think about before you order. So the physician stewardship is really coming a long way. There's a great organization called Preventing Overdiagnosis. So this is an international organization. I've been in the conference a few times. It's excellent. But it really looks at, we just really need to step back. I think with medicine, we've been doing, and the examples of prevention and mammograms every year, pap smears every year. And now we're stepping back and saying, well, let's think about this more risk-based. Let's think about this by the evidence. Not everyone needs this every year. And then also, you have tests, and that often leads to another test. So you have a CAT scan, they're so sensitive now, they're often saying, well, that was okay, but we found this, and we need to follow that up in 6 months. And you get into this just merry-go-round of tests. Another solution, or I think that will definitely help, is that we need transparency. We need to know what costs. What does $10,000 mean? What does that buy somebody? We need to have transparency in how much it is costing. Right now it's so difficult to get at what is it. I want to have this done. Somebody came in the other day from an urgent care, seeing a lot more people that what I would term underinsured, so they have high deductible plans or no insurance. How much does this cost, doctor? I'm like, I don't know. I mean, I have no idea. It's one of these, how do we get at these costs? You should be able to know how much you're paying for something up front. And right now, the costs are basically whatever people want. I mean, there's no rhyme or reason to it. No rhyme or reason. And we need to have patient and community involvement. When we look at, consider kind of the pillars of a good healthcare system, The shared decision-making, and that's where I'm really glad that we're putting it into our first year curriculum for the medical students. Like, how do you have these discussions? And so often we're used to, the doctor told me to do this, or the doctor said yes. And it's like, well, what if you don't do that? Let's talk about pros and cons of, so I would like not to do this. What could happen? And so having those discussions that, you don't need to have everything done, but you want to make sure you have the information that you need to make an informed decision. So that shared decision-making is really, I think I've just been very happy to see how much that is in our medical journals and press, and now in the medical education, that it's becoming a really hot topic. And we're also having, in the electronic medical record, a lot of shared decision-making tools that are kind of embedded. So if you come in with your cholesterol, I can kind of show you figuratively, like, what does this mean to you? What does this high cholesterol mean in terms of your risk for heart disease down the road? So we have more and more tools, but those are the discussions where it needs to be between clinician and patient in making the best decision for them. Community involvement, and when we look at good health systems, it's really around population health. So we need to know what the needs of the community. And when we step back and looking at Wisconsin, we actually are rated pretty highly among the states in terms of high quality care and lower cost relative to other states. But we have pockets. I mean, we definitely have, in terms of the opioid epidemic in rural areas, we have issues with infant mortality in Milwaukee. And so we have areas where we need to work, and that's where that community involvement and knowing what the community needs is so important. And that's where we can then shepherd our dollars to. So drugs. It would seem that a low-hanging fruit would be negotiating drug prices for Medicare. That in itself, we would save $116 million over 10 years. So not nothing. It's not a huge number when we look at the $3.3 trillion, but it's something. And that could lead to other things. I think the other things, there's a lot of reform that I believe needs to be done with Big Pharma. And one of the big ones I wanted to comment on is that, see, the counter argument is, well, we need to charge this because we have so much innovation. We need this for marketing and innovation. In the US, it's about 50% of the drugs that come to market now are what are called copycat drugs. So it's another statin for cholesterol. It's another blood pressure medicine exactly in the same class. And it's not an innovative chemical. And so what we really need is for a second drug to come to market. Right now, all they have to do is prove it's better than placebo. But I think they need to prove it's better than what already is on the market before they bring another class of statin onto the market. So these are things that can be addressed, but they really are those hard conversations, and Big Pharma is a huge lobby. I mentioned before, EHR overhaul. I mean, some people feel like we just need to scrap and start over. But I don't think that's going to happen. But it really needs to have patients, physicians, the nurses, the users design the system. Be more front and center in the design, and not administrators, software people. So the overhaul of the EHR insurance companies. So what would a high-functioning healthcare system look like? What are we really trying to aim for? When we go back to that graph of the 11, and number 1 was Denmark. But all of the ones, the top ones, are universal coverage, so everybody has coverage. They really have another foundation is primary care. And we know that the systems in areas that have good primary care base, the outcomes are better and the prices are lower for healthcare. So having a solid primary care base is so important. Population health, and they're all non-for-profit. So even though when you look at Denmark, which is a mixed system, and so it has multi-payers, but the insurance companies are heavily regulated and they're not for profit. So there are other ways to get to a universal health care besides single payer, but it also means much more tighter regulation for health for the insurance companies. So right now we have this patchwork quilt system. So when we look at the major models of healthcare, you have the Beveridge model is named after an economist in England. So their National Health Service is, he helped kind of create or design. The Bismarck model is based out of Germany, and so it's kind of a mixed multi-payer model. Again, insurance companies, though, are heavily regulated and not-for-profit. National health insurance is what Canada has, so, and it's what our Medicare is. So it's publicly financed, but privately delivered. And then you have people with no insurance, the out-of-pocket. So here, there's people without insurance. And now we're seeing more and more that we're all paying more out of pocket as costs keep going up. But the insurance companies are not, their profit is not going down, I can tell you that. So we have a patchwork model that's not working. And I think we've tried different things. So we've tried HMOs in the 80s. Now we're trying ACOs, which I call HMO 2.0. But we have this unsustainable model. And I think we need to have really hard conversations about, do we really think healthcare is a human right, or is it a privilege? Is it a public good, or is it a commodity? And right now it's a commodity. It's part of, it's this medical industrial complex. And the focus is on profit in so many sectors. So we really need to look at what do we want as a nation and how do we get there? But it's going to take a grassroots effort to really change the system, as we've seen politically how hard it is to make any change. So I think we have the roadmap to get there, and I believe we can get there, but it's going to take all of us collective effort to really raise our voices about this issue if we want to have universal health care. So, thank you very much.
Thank you for holding your questions until now. We will pass the microphones around. If you have a question, raise your hand. We'd like you to speak into the microphone because that goes through the hearing aid loop, and people with hearing aids can appreciate it. And we're being recorded for the library and YouTube, and that's kind of nice too. Who has the first question? Way in the back. I'll take a hike.
It would be nice if we would have some of our illustrious politicians here and to answer those questions that we have of them, because they are not doing their job. Both sides.
Both sides, I agree.
Hi, I'm Mayor Tracy. I was wondering if you think it would be an easier way to move to a universal healthcare system through the states or through the federal system?
Yeah, it's a great question. I think realistically, in the states, in terms of just being a bit more nimble in doing this. There have been some initiatives, Vermont, Minnesota. I think California probably has the greatest potential in the depending on the outcome of the election. That there's definitely, they have brought it up. When we look at Canada as an example, it started in one province, in Saskatchewan, and then it moved from there after it demonstrated success. So I think that that is going to be probably the way to go.
I agree with everything you've said. I've been studying this forever. I drive my friends crazy, okay? But the reality is there's a couple of, what part does personal responsibility play in this? Everything, I understand everything you said, but you know, we're a nation with alcoholism and drug addiction and smoking and you know, obesity. And, you know, I talk to my medical friends and I say, how many of the people you see are you seeing because of lifestyle choices? And it's a huge percentage.
No, you know, those are tough questions, and it just becomes such a slippery slope. Then if you know, I think that if there's incentives, and I think health insurance, you know, looking more at giving incentives for positive behavior change is the way to go. I think, and I do hear that personal responsibility, and I, you know, definitely, you know, I see that. But there's also different layers to that. So I think you can also say, oh, that person is overweight because, but there's always other layers of that story that you can't see. And so I think that it's just a hard leap. I also think you could look at, okay, we need to, because you're drinking or you're smoking or you're not exercising, it's like, well, where do you draw the line then? And, you know, what is, so I think that's where it just becomes so difficult. And that's where the community health, population health, where you can address issues more on that level. So let's look at our agricultural bill. What are we subsidizing? Process, you know, that goes into processor. You know, looking at more higher level rather than pointing to someone and saying, you don't need to, you know, you don't get insurance because you do this.
Oh, I agree completely, but we can go on for this, but my other question is, how do you get that agricultural part? I mean, you're talking about 40% of corn is going into high fructose corn syrup.
Well, it's a, you know, this is why this issue, you know, the more you get into it, the more, but I think we need to address the food. I mean, that's another huge issue it's another elephant in the room, I think. You know, it's like, look at how the grocery stores and what's in the grocery line.
I'm thinking about what he said, and so often I think people go to a doctor and they're told to lose weight, but they aren't referred to someone who can teach them to do it properly.
Or it's not covered.
Or it's not covered, exactly. And I just really feel that role model, I mean, that model should be that you see the doctor, yes, but maybe you have to be referred to the dietitian today, not next week, not 2 weeks from now. I mean, I just think the whole way we look at that, we need to hold people's hands in order for them to make those changes. And if we would put our money there, we would save so much more money on the other hand.
Yeah, there's some exciting new models in primary care that both embeds behavioral health. And so a person that has, for counseling, but also motivational interviewing. And so they can also then help people with behavioral changes. And so I think that there are definitely those missing links that we haven't had where, yes, okay, go do this. Well, how do I do that? But you're right, we need to then link them to community resources.
And the other thing is, I feel that most healthcare professionals are under a time limit. And to do this stuff, it takes time. So if you're going to make a decision about your own health care, you really need to have someone spend more than 10 minutes with you.
You're right. Yeah, exactly.
I suspect the whole country has a bit of a hubris problem. We think we put too much emphasis on medical care. provided by physicians. And I think we know from our history that our life expectancy has gone up because of public programs, immunizations, hygiene especially, nutrition. And I thought I had a point to make, or a question.
What we, and I teach the residents and the students, most of health is outside of the clinic. It's outside of the hospital. That's where most of health is. And that's where we need to reverse how we're financing. And so right now, when we look at where does all the healthcare dollars go, goes into hospitals, goes into specialists, physicians, goes to and bookkeepers and administration. So you're right. We need to look at that healthcare pyramid where we're spending, and we need to flip it because it should be public health, population health, primary care, not hospital specialty care.
Got a question here, and somebody behind you, Kate.
I do agree with everything you said. It's all thought-provoking. But where do we begin? What difference could we really make here in Alpaca? How do we start?
Yeah, great question. So I think in terms of probably low-hanging fruit is going to be around pharmaceutical in terms of at least drug negotiation, where we can make a bit of a dent. I think that can be a bipartisan issue. So I think that is definitely one. I think looking at questioning your healthcare system, how they're spending the money. Are they using value-based payment? I think beta care, that seems to be the big one is probably, you're fortunate, beta care is considered nationwide one of the leading proactive organizations in how they're doing, especially primary care for sure. So I think you're in a good spot there. But I think that would be worth a question to ask. And then from there, it's there are pockets of people working on other kind of healthcare reform. So working on single payer for statewide. And talking with your legislator about that and what their thoughts are. Because I think that's, in Madison, when I talk to people, they're on board, my island. But this is where we just need to get, from constituents when they hear the interest in different payment systems, how to get there.
Thank you.
Yeah, I had seen something on the news about these different expenses, or not expenses, but costs of the same procedures in different hospitals. No one wanted to address it from the hospitals, and you're saying we need to look at this, but we're kind of consumers in this and are stuck with whatever. And have you heard of a Blue Book pricing of these procedures?
It's called Healthcare Blue Book.
Yeah.
I just looked at it this morning, and unfortunately now it's gone that you have to subscribe to it. So you can get a little bit of information because I did want to put that up, but then it's like shoot, it's like $8 a month or something. But there are other sources that you can look at through Medicare. They have a hospital compare, so you can at least see. How does my hospital compare price-wise to other hospitals on the average?
On the website?
It's through HS, Health and Human Services, Medicare, Hospital Compare. So there you can get some information, but it's not like the Blue Book. And the Blue Book was really, is good where you can get the specific price. So, the problem is a lot of these prices are really hard to get, so you can get the Medicare cost. So a lot of them won't be able to have the Medicare. But every insurance company negotiates their own price. And so kind of what they're going to pay is, it's variable.
Got a question right here.
Yes, thank you. What is your take on this present situation of takeovers and mergers by insurance companies, the CVS, the Walgreens thing, taking over healthcare and to me, that's built-in conflicts of interest that should be addressed from a legal point, just like Roundup and Monsanto.
Exactly.
Thank you.
Yeah, I think that we're headed to too big to fail 2.0 in healthcare. That's my take. There was a recent study I was reading about that came out last week in Los Angeles. And I looked at what happened with mergers in Los Angeles. And the prices went up for procedures and office visits. Costs went up. And so, we're under this illusion. It's like, oh, we all merge together, then we can consolidate services, and we're going to save money. It doesn't save money. And so it's not been proven to save money. So my concern is we're just getting into this too big to fail. The other thing is when you get into bigger systems, and back to Terry's friend, Dr. Beasley, years ago, he had an article looking at, what's the ideal clinic size that people were happy in the clinic, because there's a lot about burnout amongst healthcare people, and it was about 4 to 5. If you get any bigger than that, people think they don't have autonomy, they can't make decisions, and then they become unhappy, and then they start not giving us good care. I mean, it's like this. So when you get to these big systems, you're just run by administrators. And again, I'm not sugarcoating moment, but our system that I'm in, it has 40 vice presidents. And it's like, who knows where to go to? I mean, it's just this huge system now, but they've done this partnership with Swedes in Rockford and over in La Crosse, and they're kind of just trying to get the bigger piece of the pie. And there is like, if they don't get bigger, they feel they're going to fail. So, yeah, it's very concerning trend. And then the other along with that is, was it Walmart? Just last week is looking at buying Humana. So,
can I hear anything? In the last 20 to 25 years, have you seen any great shift in the acute care versus chronic care situations that may contribute significantly towards these increased costs that we're seeing?
I think that I don't have those specific numbers for you. I will say that when we look at still kind of where the cost of where people is spent, chronic disease management is one of the biggest costs, and especially for Medicare. And so that is being addressed in a lot of models and trying to demonstration projects, and like how can we decrease hospitalizations, decrease emergency visits, decrease the acute kind of care because of that. When we look at overall in terms of emergency room visits, I don't think there's much of a difference, but the cost has gone up, and I think there are more testing procedures done in general per visit than there was 25 years ago. But I can't give you those specific. Were you referring to any, or is there something that you've read?
I'm sort of curious about the demographic changes that we may be experiencing, basically.
Yeah, no, it's a great question, and I'm sorry I don't have that information.
I want to put in a plug for a book called An American Sickness, and it outlines a lot of this in depth. Also, you talk about kind of the tentacles with, the farm subsidies and things like that, but education is another one, and I would think there are a lot of physicians who don't like this system, but you're a specialist and you buy into it because you're paying off student loans. So, I mean, there's just so many different, like I say, tentacles.
And you're right, in trying to address that. The average, I think, now is $240,000 that students come out, in terms of debt after school. So, and then looking at choices, and it's still a significant issue.
There was one thing from the ACA you really didn't address, which was the, no, I'm not going to say it right, but Medicaid, where the federal dollars would help with that. And it's the things I've read, the states that accepted federal dollars and did that kind of care, the costs have gone down. And the health, I don't know how the outcomes have been, but it has been better too.
Exactly. Thank you for mentioning that. Yeah, the Medicaid expansion between the states that did take it versus not, those states definitely have lower costs than other states. So it was helpful in terms of, and also obviously lower uninsured. So, and even if we look at our partner, our sister state, Minnesota, and just the differences because they took the expansion. Yeah.
We have time for about 2 more questions, so we've got one back here.
Are we ever going to see a legalized Dr. Kevorkian?
I think it's not, I think it's really state dependent, and I think that is, definitely a, issue in itself, probably for a different talk, so I'll just leave it at that, but, yeah.
I was just wondering, how we could find out from our, maybe we could go at it at a different way if we're trying to affect change. And maybe if we knew what our, the people that we vote for, what their opinions were, or if they knew what was really on our mind, maybe we could go that way.
Well, I think, for, the one positive after the last election is, for one of the positives is that the people that really stood up and came out and talked and were like, we're not changing healthcare the way you're talking about changing healthcare. That's going backwards. So I think that there is, that people came out and politicians listened.
They listened, that's nice.
So keep talking.
Well, before we give Dr. Stiles her final thanks, let me just say anybody who's willing and able to help us stack chairs, we put them on the little trolleys, and the library really closes up at 8, so we do have to wrap it up. But that was wonderful, Melissa, and I appreciate you coming up, and let's give her a big round.